Hi guys, this is your friendly neighborhood pediatrician Dr. Aditya Bhatt, and we'll discuss today about paracetamol poisoning. Paracetamol poisoning is one of the most common cause of hepatic failure in pediatric patients, and if you take etiology wise the reasons for pediatric hepatic failure, it is the single most common cause of pediatric hepatic failure. As you all know that there is depletion of enzyme NAPQI, and that is the cause of hepatotoxicity. So first question is that what is the toxic dose? The toxic dose of PCM is 200 mg per kg. That is the toxic dose for paracetamol to cause poisoning in pediatric patient. Now clinical features of pediatric in pediatric age group, there are phases, and we'll discuss something about phase. So phase 1, the clinical feature, the phase 1 has absolutely asymptomatic and non-specific signs, and it lasts from 6 hours to 72 hours, and patient is either asymptomatic or has non-specific signs like anorexia, abdominal pain, diaphoresis, malaise and everything. Then comes the phase 2, which lasts from 18 hours it lasts till 20 hours, so 18-20 hours to 72 hours. Now in phase 2, there is a specific abdominal pain in right upper quadrant. There is pain which is suggestive of hepatic etiology, and there are signs of hepatic failure like nausea, vomiting, there is decrease in consciousness, there is hypotension, there is oliguria. Now in phase 3 lasts from 72 hours to 96 hours, and it is a more specific hepatic phase in which there are all signs of hepatic failure like jaundice, encephalopathy, acute renal failure, severe hypoglycemia, coagulopathy, and the patient lands up in hepatic failure, hyperacute hepatic failure. Now we'll discuss some more MCQs, that what is hyperacute hepatic failure. Then there are signs of hepatic failure that occurs within 1 week. Now soon I'll have lecture on hepatic failure, so we'll see the clinical features and definitions of hepatic failure. But now remember that if there is a hepatic failure within 77 days, it is called as hyperacute liver failure. Now phase 4 we have resolution of symptoms. As you know that liver tissues and liver cells have absolute awesome capability of regeneration and recovery, so there is recovery in the patient, and it normalizes, the hepatic enzyme normalizes. Now as you all know, the drug of choice for PCM poisoning is N-acetylcysteine. Now N-acetylcysteine, what is the dose? The dose is same that as the toxic dose, it is 200 mg per kg. It is given, and it can be given up to 300 mg per kg, but for the ease of simplicity we take 200 to 300 mg per kg. And usually we plot normograms. There are normograms plotted to see that when the patient comes to you, if that we plot the normogram of PCM levels inside the blood, and we check for the if the normogram is crossing the line, and if it is crossing the line, then we suspect that the patient requires N-acetylcysteine. We do not give all patients N-acetylcysteine. So first question is that we plot the graph only after 4 hours of poisoning. So if patient has taken at assume that 12 p.m, so we do not plot the normogram before 4 p.m. So we assume that it takes up to 4 hours to be plotted on the graph. If it is less than 4 hours, we give symptomatic treatment. We wait till 4 hours, and after that we give the treatment of N-acetylcysteine. Again, if there is very severe poisoning and the patient is very toxic, then we do not wait for the normogram. If there is a single acute ingestion, and between 4 to 8 hours we can plot the normogram, and we give the treatment of N-acetylcysteine. Now ideally the treatment of N-acetylcysteine is given in a range of 20 hours. So we give loading and maintenance dose. And another question that might be asked, that what are the criteria of liver transplantation in PCM poisoning? So we usually give liver transplant in case of PCM poisoning if INR is more than 6.5, or it compared to the control, or it takes more than 100 seconds to PT for to clot the blood, or if there is a hepatorenal syndrome, or if there is a severe necrosis and there is the AST and ALT are in thousands. Now another question that might be asked is that what are the conditions in which we find the transaminases reaching the thousands level, like the AST and ALT are 1000, 2000, 3000. So it occurs in hepatitis, it occurs in infarct of the liver, and it occurs in PCM poisoning. There are multiple other causes also, like HLH and everything, but the most common three causes are this: that if the patient has PCM poisoning, there is hepatitis infection, or there is a hepatic infarct. That's all for today, guys. I hope you enjoyed the video, and if you like the video, please give a like, share and subscribe, and please share this video to other people so that they might also be benefited. Thank you.